Hello again. Okay, here we go. This is fundamentals, and we're delving into pain and pain management. So let's rock and roll. All right. So, what is pain? Quote, and this is from the International Association for the Study of Pain, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. End quote. What do I say? I've been saying this for years. Pain is whatever your patient says it is. Okay. So, so pain, we have pain for a reason. It's a distress signal. So it's the body's way of warning us that something is hurt. And it's very difficult to ignore pain. And it's one of the most common reasons that people go to the hospital or the doctor. They're seeking relief. And people will try anything when they have pain. And this is an ongoing challenge, not just for nursing, but for the healthcare industry in general. So pain is a subjective symptom. So it's whatever your patient says it is. The client's report of pain is the best indicator of pain. And if your patient says their pain is a 10, you have no choice but to believe them. So even though it's subjective, it's documented as the fifth or sixth vital sign because we can't be inside the person's body to feel what they feel. So if they tell us that they feel their pain is a 10, their pain is a 10. Okay. Why? What are the causes of pain? So pain can be caused by something mechanical. In other words, a trauma, you fell, spinal injury, a surgical incision, the growth of a tumor, can be because of things like pressure or too much heat or too cold. When there's damage to tissue, chemical substances get released, and that helps to send the signal to the brain, hey, this hurts. Lack of oxygen to tissues like a heart attack, an MI, myocardial infarction, is painful. Muscle spasms are painful. Even if we can't find the exact and definitive cause of pain, it doesn't mean that they don't have pain. So the pain is real to that patient. And sometimes we can't find a reason. Okay? We have acute pain and we have chronic pain. So acute pain is something that is short term, right? There's a specific injury or an illness or a disease, and it serves a purpose because it's associated with spasms and sympathetic nervous system activation, and it's self-limited. In other words, it doesn't last long. So if you sprain your ankle, right, it's going to hurt, but it's not going to hurt forever. It's probably going to hurt for a while. And then it's going to intermittently get better, better, better till it's gone. Chronic pain, it's really kind of a disease state. So it's pain that outlasts the normal healing time if it's associated with an injury or a disease. So if you say had surgery, you have pain, the pain should be getting better. Or you were in a car accident, you have pain, the pain should be getting better within a week, 2 weeks, 3 weeks. If it lasts more than 3 months, it's then considered chronic pain. And chronic pain can be caused by lots of different things, sometimes back injuries, right? Spinal injuries can hurt for a long time. There is a cycle that goes on when people are in pain, especially with chronic pain. When something hurts, you get tense and then you get stressed. Well, and all of that's exhausting. So now you're tired. Then you're either scared or you're angry or you're frustrated. And then you become depressed. Oh my God, is this ever going to end? Which leads to more pain. So you see how that cycle just keeps going around and around and around. It's really hard to break the cycle. So how does pain get transmitted? Okay. So there's something called nociceptive pain, which we're going to talk about the different types of pain in a minute. But transduction is when the nervous system changes whatever the painful stimuli to impulses and the transmission goes to the brain. The brain recognizes it, defines it, that's your perception, and responds to it. And then modulation is when your body does different types of inhibitory responses. In other words, if something hurts, you're going to favor it. You're not going to want to use it, right? That's an inhibitory response because of the pain. If your foot hurts, you're going to favor the other foot and not going to want to put weight on the foot that hurts, right? Makes sense? So what are the different types of pain? There's nociceptive pain. That's pain, and you need to know this. Pain that comes from damage or injury to muscles or tissues. And nociceptive pain can be considered superficial or visceral. Superficial is also known as somatic, and that means it's coming from something superficial, your skin, your muscle, your soft tissue. Visceral is deep. That's deep pain. That's coming from internal organs or blood vessels. Okay, so understand nociceptive pain is from an actual injury or damage, and it can be superficial, also known as somatic, or it can be visceral, deep. Okay, then you have neuropathic pain, which is nerve pain. Think of things like diabetic peripheral neuropathy, right? Or fibromyalgia, nerve pain. Then there's something called referred pain. That's when you have pain in a location other than where the injury is, right? Think about an MI. Oftentimes people will have neck pain, back pain, arm pain, when really the heart attack is what's happening. Intractable pain. When we talk about the word intractable, that means we can't relieve it. It's difficult to manage. And then, of course, we have acute and we have chronic. Quick onset, quick duration, chronic, it's going to last. It's more than 1 to 3 weeks, usually 3 months or more. Okay. So chronic pain is a problem. And what can chronic pain do? The results of chronic pain can be really bad. People feel like they're out of control. They have no self-control. It affects their personal life and their roles and responsibilities with their loved ones, their family, their friends. It changes their whole outlook on life. It causes depression, decreased communication. I'm going to add depression here. Depression and extreme fatigue, like we talked about in that cycle of pain. Makes it difficult to communicate. It can break down entire families. And sometimes families can get aggravated because now they have to pick up the slack. Well, you're in pain, so you can't do X, Y, or Z, and now we have to do it for you. So that becomes problematic. So really, chronic pain can really ruin somebody's life. Okay, it really can. And we need interventions to address chronic pain. So we have to break that cycle. And there are different ways of breaking the cycle, because sometimes if we don't break the cycle, it can even wind up with such severe depression that they can have suicidal ideation. Like, I can't live with this anymore. I may as well just not be here. Referred pain. So here you go. Referred pain is an area far from the primary site. Okay. So, if your heart having a heart attack, like I said, you can have pain in your shoulders and your heart and your back, your arms, right? So that's referred pain. Radiculopathy. Radicular pain. Okay. Radicular pain is pain that comes from an injury from your spine. Okay. So it's also called radicular or radiating pain. So in your spine, you have your vertebrae, which are the bones. Okay. And your spinal cord runs through the spinal canal, which is in the middle, right, of these bones. This is a view from the top. The nerve roots, all the nerves in your body come from the spinal cord and exit through those little bones in the vertebrae, and they go to your whole body. Well, if there's damage, say to the disc between the vertebrae, and the nerves are getting squished, compressed, you'll have radiating pain that'll travel a dermatome. What's a dermatome? Good question. A dermatome is an area of skin or an area of the body that's innervated by a spinal nerve. So this chart can really help you understand. So if you have a herniation, say at cervical 5 or cervical 6 or cervical 7, you can see where that pain would radiate to in terms of your hand or arm. Same thing with your lower spine. Injuries at L4, L5, S1 go all the way down the leg. Okay, so that's radiating pain or radicular pain. Travels a dermatome or a nerve root. Question, is this true or false? If a patient with chronic pain states that they can't sleep, you should consider that maybe they're depressed. True. When people are depressed, one of two things can happen to their sleep. They can either just constantly sleep or never sleep. Okay? They can have lack of interest in things around them. They can either not eat or eat too much. They can have feelings of guilt. They can withdraw from social activities. They can even have trouble with sex, because if you're in pain, you don't feel like doing that. All right, so factors affecting pain perception, or perception of pain. So there's something called a pain threshold, and that's the point where the person becomes aware of the pain. A pain tolerance is the point where you just can't take it anymore. That's as much as I can take. I've reached my tolerance. Endorphins are substances that we have in our body, produced by our central nervous system, that actually relieve pain. When we exercise, when we laugh, when we're in a good mood, we can even force ourselves to do these things to get those endorphins flowing, and they can actually help a little bit to relieve some pain. Things that decrease the production of endorphins: caffeine, excessive caffeine, nicotine, not for me, alcohol, salt, and sugar, right? So if you're having some pain, one of the things that you can do, as long as it's not horribly serious pain, if you like music, turn on the music, sing, watch some stand-up comedy, things that can actually make you laugh. You can actually talk your brain into believing you're in a good mood, and you'll actually be in a better mood because it'll produce those endorphins. This is true. What is perception of pain? So the perception of pain is the sensation and the experience associated with usually tissue damage, right? And we did talk a little bit about the transduction, which is activation of the nociceptor. In other words, I cut my arm. That's the activation, and it's transduction. Oh, ow, that hurts. So when I cut my arm, transduction occurs, and then the signal from that cut gets transmitted through those afferent nerve fibers up the spinal cord to the brain. Okay. And then modulation occurs where it goes to the higher brain and it gets interpreted. So now my brain's going, my arm hurts. Okay. Know the 3 steps: transduction, transmission, modulation. Okay. Now, pain can be expressed by different people in different ways, and it's important to keep this in mind. There are certain cultures that tend to be stoic. And actually, I want to include stoicism. I'm going to put that right here. Stoicism. Stoicism is that got to be tough. Can't cry about it, right? Being stoic. Older folks older than me, like in their 70s and 80s and such now, if you ask them if they have pain, if you just ask them, do you have any pain? More than likely, their response will be no. You have to ask more questions. In other words, you have to ask them things like, are you stiff when you get out of bed in the morning? Do you find that it's a little more difficult to do some things like mow the lawn, that you used to do easily before? You have to really kind of pull it out of them, because they tend to be stoic and go, I'm not in pain, I'm fine. And culturally and gender wise. So, traditionally back in the day, a man, I don't feel any pain, I'm tough, whereas women would be more inclined to talk about their pain. Different cultures also believe that pain can be a punishment because you did something wrong. So all of these things affect the way people will express their pain to you. So it's important to keep that all in mind. It's really important to assess pain. I'm not going to have you go through all of this, right? When it was determined that it was part of the vital signs. But we do need to make sure we understand that for accreditation, people have to understand that we don't withhold meds from people. So there's an opioid crisis, we know, that's been going on for a minute in this country. However, we can't go to the extreme other side and say nobody gets any pain meds, because when you're in pain, your blood pressure goes up, your heart rate goes up. It actually impedes the healing process, right? So we need to make sure that we are safely monitoring and managing people's pain, all right? Not that we completely cut everybody off from pain relief. Documentation. How do we document? Well, we document what is the level of pain, rate the pain. And we're going to take each of these and break them down so that you understand. Describe the pain. What did you do as the nurse? And how did the patient respond? Okay, those are the 4 important things that need to be documented when you're caring for somebody that has pain. So how do we document the severity of the pain? We use pain scales. So for, cognitively unimpaired people, awake, alert, and oriented, we use the pain scale. And we tell them on a scale of 0 is no pain, 10 is the worst pain you've ever had. What number would you give your pain? And as you can see, through 3 is kind of mild, 4, 5, 6, moderate, 7, 8, 9, 10, that's considered severe pain. Okay. Then we have something called the FLAC scale. And the FLAC scale is used for babies. What it does is it looks at 5 different things in the body and gives it a rating. You look at the baby's face. Do they have no particular expression? Or are they smiling? Or occasionally are they frowning or grimacing? Or are they constantly frowning or clenching their jaw, quivering, right? And we give them a scale of 0, 1, or 2. And we do that for each of these categories, and then we total it up at the end. All right. So, we look at their legs. Are their legs kicking, drawn up, or are they just kind of normal? Activity. Are they just lying quietly? Are they squirming around? Or are they screaming, right? Are they arching their back, jerking around? We look at their cry. No crying, little bit of crying, really crying, screaming. And then we look at something called consolability. Can we console them if they are crying? So a 0 would be if they're already content and relaxed. If they are a little uneasy or restless, can we console them by reassuring them or hugging them or touching them or, swaddling them? Then that's a good sign. If we cannot console them, right, or comfort them, that's a bad sign. That means they really do have some significant pain. And then you just add up each of the categories, what score they got, and you come up with a score. And then for children, like toddlers, and also for developmentally impaired people, we can use the Wong-Baker Faces scale. And the scale correlates with the pain, the numeric scale, but it's got faces. And you just say, point to the face that feels like you. Nothing, little bit, little more, literally more, a whole lot, or it's the worst. So whatever they point to is what you use to interpret the scale. Then there's something called the pain ad scale, and that's used for patients with advanced dementia. It's kind of like the FLAC scale because it's done by observation. We're looking at their breathing, any negative vocalization. Are they moaning or groaning? What's their face look like? Are they grimacing or frowning? Body language, relaxed or rigid and tense? And can we console them? Right? Are we able to hug them and comfort them and they calm down? Or no matter what we do, they're just, okay. And then we come up with a score, and that tells us their level of pain. So these pain rating scales are great because it's a universally accepted and understood way to measure the pain of someone, even if they can't speak. Okay. I'm going to skip this one because we're only using the FLAC scale. How do we document when we're talking about someone's pain? How do we get them to describe things like the character of their pain? Is it aching, burning, cramping, crushing, dull, sharp, tearing, throbbing? You can read radiating, sharp, shooting, stabbing. That's the character. And when we talk about character, I'm going to throw another word in here. What we're doing is we are qualifying the pain. Okay. We're describing what does it feel like. And then we want to know how long does it last? What's the duration of the pain? Does it come and go intermittently? Is it spasmodic or is it constant? When we talk about the severity of pain, that's when we are quantifying it. So let me add that here. Severity is quantifying. We're putting a number to the pain, okay? 0 to 10, or the FACES scale, or the FLAC scale, or the pain ad scale. We're putting a number to it. And then associated factors. Anything going on while you're in pain? Are you having some nausea, vomiting? Or have you lost your appetite? Do you feel depressed or suicidal? Anything that's being felt by the patient as they state to you along with the pain. Wait, there's more, okay? Then this cold spa, that's one acronym that we can talk about. The character, of the pain, describing it like we just talked about. When did it start? Okay. Where is it? Internal, external. Does it radiate? How long did it last? Right? Is it still there? Does it come and go? How bad is it? Put it on the scale. Pattern. Does anything make it better? Does anything make it worse? Right? And then any other associated factors or related occurrences like precipitating factors. So related occurrences or precipitating factors. Did you fall and then your back hurt? Right? Or do you have symptoms associated with the pain, like a headache or your eyes hurt, the bright light is painful, those kinds of things. We have to document all of that, okay? So when we intervene, after we've documented what the patient has told us about their pain, the character, the duration, etc., let's say we give them a pain med. Well, we always have to check back after we give the med in a reasonable amount of time. Did it work? Did it work? So for example, if you went to your patient and said, rate your pain on a scale of 0 to 10, and they said, oh, it's an 8. Okay, we give them a PO medication. We wait 20 or 30 minutes, then we go back in and we ask them, how's your pain? If they say, oh man, it's down to a 2. Well, we know it worked. So that's all you have to really write. Patient states pain now 2 out of 10 on scale, which tells me that what you gave them was effective, right? That's all you have to write. With pain management, the goal is to manage the pain, right? Sometimes we have to try a lot of different things. And there are things other than medications, but let's talk about all those things, okay? So we have medications, analgesics, okay? Non-opioid, non-steroidal, anti-inflammatory drugs, NSAIDs, include aspirin, ibuprofen, Advil or Motrin, naproxen or naproxen sodium, which is Aleve, celecoxib, Celebrex, meloxicam, Mobic, indomethacin, Indocin, ketorolac, diclofenac. All right. So those are all non-steroidal anti-inflammatory drugs. And once we get deeper into pharmacology, we'll talk about, they all share the potential to cause GI bleeds. One of them, the celecoxib, I'm going to put a little asterisk, is the only one in that group where if somebody has cardiac issues, they can't have that drug. Then other analgesics, acetaminophen, good old Tylenol, not anti-inflammatory, right? But it can help with some pain. And then we have our opioids or our narcotics. And this list includes fentanyl, morphine, buprenorphine, hydromorphone, also known as Dilaudid, oxycodone, when you put it with acetaminophen, that's Percocet, meperidine, Demerol, codeine, and tramadol. Get rid of fentanyl here because we've got it twice. So those are all the opioids. And they all share 3 major side effects or adverse effects: respiratory depression, urinary retention, paralytic ileus. Respiratory depression, urinary retention, paralytic ileus. Remember that for opioids. And we'll talk more about it when we dig deeper into pharm. We also have adjuvant drugs, like I said earlier. An adjuvant is when we add a drug to another drug to help it. So that's like acetaminophen with hydromorphone, right? Then we have off-label uses of drugs. For example, Neurontin is an anti-seizure or an anticonvulsant drug, but we use it for nerve pain for fibromyalgia or diabetic peripheral neuropathy. Antidepressants. Amitriptyline is a tricyclic antidepressant, but it's used specifically, and you need to know this is a board question. Amitriptyline is used for pain relief for trigeminal neuralgia or post-herpetic neuralgia. Okay? So trigeminal neuralgia, the trigeminal nerve in the face, it's almost like a Bell's palsy, but not quite. Post-herpetic neuralgia is the pain that is felt after someone has had the shingles. And that will hurt forever. Okay. So amitriptyline, a tricyclic antidepressant, is used to manage pain of those 2 types of diseases. And pretty successfully, by the way. How do we give these medications? We can give them by mouth, PO, intramuscularly, intravenous, which, by the way, is the quickest way to get pain med into somebody. There's also transcutaneous, like a transdermal patch, fentanyl patch. Topicals, diclofenac gel, which is that NSAID ketorolac, comes in a gel. It's a topical if you have neck pain, back pain. Epidural, some of you that have had babies that have had epidurals, it's right into the spinal canal that numbs and kills pain from the waist down. And then PCA pumps, patient controlled analgesia. And with these pumps, the patient gets a basal rate and a bolus or PRN dose. So it's an IV hooked up to the patient, gives them a continuous dose, say morphine 1 milligram an hour. They are continuously getting morphine around the clock, but also they have a little button. They can push the button to deliver a bolus, an additional PRN dose. Say they are allowed to get 1/4 milligram of morphine every 15 minutes. There's a lockout on these devices. So in other words, once it's filled and programmed, the patient will get their basal rate, that 1 milligram an hour, let's say. And then if they push the button, they'll get their bolus. But if they keep pushing the button, they won't get any more. So they can't overdose. Okay. So they'll only get whatever is programmed for them to get. So 1/4 milligram every 15 minutes, they can press that button till the cows come home, and they're not going to get another dose until 15 minutes has gone by. Make sure you know that. Okay. Then there's alternative and complementary techniques to pain, chiropractors, acupuncture, acupressure, hypnosis, massage, biofeedback, which we'll talk more about later, homeopathy, flower essences, aromatic oils, and herbal remedies. I mean, you know, no proof, but some people, if the patient says that it works, then it works. I have a friend who has acupuncture. She's been having it done for years. She says that her pain is gone. Her back pain is gone with acupuncture. Her back pain is gone. The acupuncture works for her. So it really depends on the patient. Regular use of pain medication in acute pain can lead to dependence on drugs. True or false? False. Okay. Dependence does not occur when you need relief from acute pain. Okay. So that's less than 1% of opioid addiction is due to someone who had acute pain and was on pain meds for like an accident or something. Okay. So just so we keep that in mind. And then we can do surgery. So hang on one second. I'm going to have to pause for a moment. Sometimes the only thing we can do is surgical intervention. For example, a herniated disc in your back may be so damaged that the only thing we can do to relieve the pain is give you surgery. Or if there's a tumor that's pressing on something, we may have to do surgery to remove the tumor. So that's sometimes, or they're the only alternatives. As a nurse, what are you responsible for? Monitoring the patient's response and their vital signs. Real important, especially with opioids, with any of the meds really, but with opioids, you're monitoring respiratory rate first with opioids, respiratory rate and urinary output, right? Because opioids cause respiratory depression, urinary retention, paralytic ileus, bowel sounds, bowel sounds, bowel sounds. Also monitoring for constipation or potential GI bleed, because that is a side effect for NSAIDs and aspirin. And then also we can do other things that are meant to complement, in other words, add to, but not replace medications. Okay. Things like diversion, changing their position, giving them a bath or a back rub or a little massage sometimes can help. Making sure they're eating properly and getting adequate fluids. And then sometimes side effects like constipation or nausea, we can give another medication to help prevent those things from happening. Okay. And we already talked about things like, physical measures, like a heat pack or ice if it's a fresh sprain. And then distraction, diversion. Guided imagery is telling the patient to close their eyes. And this you need to know, just this one thing. Close your eyes and imagine you're somewhere that's the best place you ever would want to be. So like for me, I love the beach. I would picture myself on the beach. And then you guide them through. You're on the beach and you can hear the waves crashing in the ocean. You can feel the sun beating down on you. Sometimes that can help. Again, not meant to be replacements for other interventions, but definitely these things can help as adjuncts or add-ons to the medications. Okay. And then for patient education, whatever meds you're giving them, make sure that you have explained what the drug does. its effects, what the adverse effects could be and what they should report, what's their dose, how often do they take it, and for how long, any drug-drug interactions, any safety measures that they need to think about when taking that particular drug, and any special considerations. Side effects, like some drugs can discolor your urine, right? So they need to know all of that. And that's your responsibility. Okay, so make sure you know that. And you're always using the nursing process. That's something that never changes. Whenever you are dealing with a patient, you are assessing or gathering data, coming up with a diagnosis, then you're planning what you're going to do and you're implementing it, and then you're evaluating it to see if it worked. All right, last question. Is this true or false? The nurse should always utilize a comfort measure to alleviate a patient's pain before requesting a pain med. If you said false, you were right. So remember, comfort measures aren't meant to replace meds. They're just meant to complement them. So encouraging them to do different things like guided imagery can help decrease the pain, but certainly it's not meant to replace medications. Just remember that. And that's all, as if that's not enough. All right, so until next time, I will see you guys later. And remember, the things that are highlighted are the things that you do need to be aware of, okay? And I'm signing off. Until next time, see ya.